you are already aware that we have 3 new faces on our team, Riley, Barney, Anna Velasquez, and Monica Mills. We're going to give them the opportunity to introduce themselves. But just for some context, previously we've spoken about how there are 2 portions or 2 segments of the New Choices Waiver team, the operations team and the services team. Riley and Anna are on the services team and complete tasks such as incident management, follow up on health and safety agreements, ask you guys to do health and safety checks for individuals, and kind of are more focusing on service delivery, training, etc. And then the operations team has the heavy emphasis of applications, enrollment, and provider support. So with that, we'll put people on the spot here. Riley, do you want to go ahead and introduce yourself?
Sure. Hello, everyone. I'm Riley Barney. I've probably communicated with a good handful of you. And yeah, just what Lainey said, I'm on the services team, and we probably talk with each other mainly about incidents and health and safety concerns. So yeah, that's what I get to do on this team.
And Riley has actually been with the state for a little while. She was promoted from another position in our bureau, so she's not a new. Riley,
I think she froze up. Oh, okay. But yeah, I've been with this bureau since 2019, so a couple of years now, and so yeah.
Great, thanks. All right, Anna, are you with us?
Yep, I'm here.
Great.
Hi, everybody. I'm Anna Velasquez. I'm with Riley and Marisol on the team. So yeah, I've probably spoken to you either via email or sometimes on the phone, working on incidents and health and safety. I've been with the Bureau for about 2 months now, 2.5 months. So yeah, so I'm pretty new to the team, and it's been great and learning a lot.
Thanks. All right, Monica.
Hi, everyone. My name is Monica Mills. I am brand new to the team. This is my 3rd week, so I have not corresponded with anybody. And if I do reach out, please be patient. I'm learning, but I'm really eager to be part of the team. I'm going to be working a lot with provider enrollment and some hearing tasks, as well as just answering phones and trying to help as I can. I have some experience with home and community-based waivers back home. I'm from Alaska, and I just moved up here recently, so I'm excited to be in Utah and to learn more and get to interact with everybody.
Thanks, Monica. So we've collected kind of short bios for everyone. Since we have new faces and kind of new roles on our team, you guys have been asking for a little while for a contact list and an explanation of who is doing what, since it seems like we're constantly making changes, and we are now ready to put that forth since we have a complete team. So we're really happy about that. There's an update on Amelia's team. Could you share that update, Amelia?
Yeah, just 2 quick updates. As Lainey mentioned, we'll be sharing a summary of the team and their roles, but we just wanted to make you aware that we have made some changes. And so Blake, who has been managing our provider enrollment for several years now, is actually going to transition over and help us with eligibility determination or applications. And as Monica indicated, she'll be your point of contact for provider enrollment or provider related questions. So we just wanted to make you aware of that. And to help with our communication around provider related questions, we've actually created yet another email. To us, it helps us. For you all, it might be a little frustrating to know which of the 3 emails should I use. The nice thing is if you send it to one and it's not the correct one, we'll just forward it to the correct one. But I'll put this in the chat. It's ncwprovidersupport@utah.gov. And so we're just asking that any provider related question that could be related to enrollment, billing, just general questions, please direct those questions to this email. And that way we can ensure that Monica and Blake, who will also continue to kind of assist in a backup role, have access to those questions and can respond in a timely manner. So I'll share that again in the chat, and we'll also send out an email with that information.
Yeah, I think our goal with these central inboxes has been to make communication easier for you guys. So instead of having to remember emails and who exactly is doing what, and maybe not getting a response for a while if one of us takes some time off, we have a central inbox so that we can staff it as our needs change on the team, and there's not an interruption in accessibility for us. So thanks for coming along and making that change with us. So far, we've seen some great results with that. If you have any concerns or questions, let us know, but we will continue on with that strategy. So this will be coming in written communication to be effective for the entire program starting in January. A policy change will go into effect in January. You'll see it announced formally through the Medicaid Information Bulletin, or the MIB, and an update to the provider manual. That requirement is going to be sending for case managers to send a copy of the care plan, the PDF that is generated from the care plan system, as well as the PCCP addendum to all other providers listed on the care plan. So we will be incorporating a slight modification to the service authorization form that just indicates, providers, by signing this form, acknowledge receipt of the care plan and the PCCP addendum along with this service authorization. This is to meet a requirement that CMS has, that care coordination be interdisciplinary, if you will, between all providers on the care plan, and that everyone is informed of what's needed. Part of this is in response to the state's efforts to demonstrate compliance with, we've talked about this in the past, the settings final rule. If you have more questions about why exactly we're doing this and what's needed, please send those to me, because I don't want to bore you with the details if you're not interested in them. So if you have questions, let me know. That will be effective for all services on the care plan and all providers starting in January. As of October 1st, we just need you to send the care plan and the PCCP addendum along with the service authorization to adult day health providers. So if any of your existing clients or new enrollees as of October 1st will have adult day health on their care plan, we need you to start that process now. And that is to facilitate the state and our program coming into compliance with a broader federal rule. So we will put this out in email, hopefully through a policy clarification notice, so that you can distribute this to your staff. And hopefully that will make that a little bit easier. Let's see, we have a significant level of difficulty getting providers to return signed service authorizations. We spend a significant amount of time emailing and calling them to get authorizations back. I understand. If you have any suggestions for what support we could offer that may help in that effort, let me know. When you've heard about this mysterious PRISM system that will go live in 2023, hopefully, that system will be sending service authorizations to providers. So you will no longer, Tracy, nag. Yep. I feel like that's part of the job description of social work, like professional nagger, right? So that system will be sending service authorizations to providers. So I don't think we will be tracking down signatures any longer, which will alleviate that burdensome process. So from my perspective, it's kind of like hobbling along until then, but we're willing to try to problem solve any challenges that you may be running into. So let me know what you think would be helpful there. And then last update, over the weekend, I emailed the case management agency supervisors a survey, a Google form to complete. Some of you have already sent that out to your staff. I really appreciate that. I'm hoping to get feedback about what specifically is needed for process improvements for care planning. We have heard, particularly at last month's CMA forum, that additional training, clarification, standardization is needed to accomplish everyone's common goal of getting an approved care plan faster and with less rates of back and forth. And we've heard some generalities like, guidance is conflicting, or there are inconsistencies among reviewers. And I'm hoping to get very specific information through this survey. So I am approaching this by assuming positive intent. And so by asking for specific information, such as the service where this occurred, what guidance was given between two of my team that conflicted, what guidance was given that may have conflicted with written instruction, if the written instruction is in conflict with each other. So anything that you may have been otherwise hesitant to share in a public forum, please share that information through this Google form, because that will help us with these process improvements. So I'd like to have all of that information by next Friday, September 17th. So if you could please get that out and back to me, that would be great. We are shooting for having a care plan, guidance, and materials to share for I believe it's November or December. I can't quite remember. We've got a training schedule. So in the next month or two, we hope to have that reviewed. So please help us out there. And just know this is coming from a place of partnership, and we'll assume positive intent and help us out here. So with that, we want to get into the meat of our meeting today, which is the medication management review. So this is a long time coming. We implemented this, I think it was January of 2019, before we had any wind of a pandemic, and we had intentions of revisiting the process and hearing from you all how it's going about 3 months later, and then things kind of went south. So we are acknowledging that the delay that has occurred, and are happy to now be at the place where we can revisit this and work together to see what's working and what's not. So Marisol is going to be presenting today kind of a summary of the information that was shared in 2019, as well as little tidbits that we've heard need clarifying since then. And then I believe there are some parts in her presentation where we are hoping to get your feedback to help clarify things. So with that, Marisol, I will turn it over to you.
Great, thank you. So I'm going to be presenting today, which unfortunately means that I might not be able to see any sort of chat function. So in the case that you have any questions, I want this to be very conversational. Go ahead and unmute yourself if you feel comfortable. If not, you can go ahead and ask questions in the chat function. And I've asked other staff members to hopefully help and assist, with those sorts of questions that are pertinent to these topics. So I'll go ahead and present my screen. Okay, so first off, I do want to relate with you and let you know that I have worked as a home health nurse case manager. So I've been in your shoes before, and at that time I was expected to reconcile each and every medication In this case, with the medication management review process, it was not the expectation for nurses to have to review each and every single medication. This is not bedside nursing. And so the expectation is not that you account for each and every single thing, that you're looking at the 5 rights, but rather that you're looking at this review, taking an overall approach and ensuring that there are no health and safety concerns relating to medication or labs. So I wanted to first discuss some of the information available in the Nurse Practice Acts. For example, that nurses are to base nursing decisions on nursing knowledge and skills and the needs of patients. We should be seeking clarification of orders when needed, take preventative measures to protect patients, others, and yourself, and promote a safe patient environment. In addition to that, RNs are expected to determine whether and according to what time frame another medical professional, a patient's family member, or any other person should be apprised of a patient's nursing needs, intervene on behalf of a patient when problems are identified so as to revise a care plan as needed, and appropriately advocate for patients by identifying unsafe care situations and correcting problems or referring problems to the appropriate management level when needed. So again, we're looking at the larger picture, when you're doing your medication management reviews. To give you a brief background of the processes that occurred prior to implementation, there was a work group that was set up in the pre-implementation stage with agency nurses, asking for input. December 2019, unfortunately, that happened to be a month right before I started working for New Choices Waiver. There was a form that was created, which is currently the form that's being used. And then it was finalized and sent out. The process was requested of agency nurses January 2020, the month that I started. So with the with COVID occurring, the initial what had been planned was a reevaluation of this process, but unfortunately COVID hindered us from being able to do that. So at this point, this is what we're starting to do. We're starting to reevaluate this process. I'm hoping for some input from some of the agency nurses so that we can make those adjustments, and then eventually be able to draft some sort of guidance material so that there's some standardization to this process. So as many of you know, this is the medication management review form. The first page is used alongside your initial MDS-HC assessment when the client is first enrolling onto the New Choices Waiver program. And then this is to be used quarterly thereafter. Again, we couldn't account for something like the public health emergency occurring where care plans were being extended. But this page was used basically for quarters 4 or quarter 5, for example. Does anyone want to give me any input on whether or not this form has been useful, or if you've experienced any hindrances or challenges using this form? Anything that you question about this form? And I'll go ahead and open the floor for some moments here.
Yeah, go ahead, Shannon.
And you're welcome to unmute yourself, Shannon, if you want to go ahead and ask that question.
There we go. Wrong unmute button. Sorry, guys. Anyway, so my big concern, well, not even a big concern, is where that says like we're 3 months of labs done. So like if somebody's taking a diuretic and they should probably have a BMP done for that diuretic along with like the potassium they're taking. Mm-hmm. My social workers are like, yeah, they see their doctor. And it's like, but how do I, like, without calling everybody and jumping through all these hoops, know that my forgetful patient's potassium level's normal, you know.
Right.
So
Shannon, are you coordinating with your case manager? Or are you coordinating directly with whoever's in charge of those labs?
So I'm following up with the case manager and just saying, hey, are these getting done? And then I don't really get I get a varied response of, oh, home health checked that, or just I say, to cover my butt, do I just say social worker said this is being taken care of, or social worker said client sees doctor every 3 months and labs are dealt with then?
So you're going to coordinate that with whoever's taking those labs, actually.
Okay.
What you're going to be doing is reaching out to that home health agency. And if the home health agency assures you that, you know, everything's has been taken care of over the last 3 months, and that everything is within normal range, and the client's been compliant, you can just document that. So we're not looking for specifics. So like I said, as a home health nurse, you might look for those specifics. In this case, you're just looking to identify if there's any sort of health or safety issue. And so based on that sort of interaction, I think you could easily, you know, say whether or not you feel there's an area of concern or additional follow-up that should be needed.
All right, and then my other one in general, sorry, I'm a little late to the party. I come across like where I'm looking through Mars Monthly, and where a doctor would order a pain medication, so say like Norco, 3 times a day. And so I'll find that sometimes it'll be given and then it's given an hour later, but then I get the doctor ordered it 3 times a day and he knows best. And in my brain, I'm thinking, if you're taking these pain pills every hour for the next 3 hours, then you're going to fall on your head.
Right. And so again, that's a really great example. You're identifying that there is a health and safety concern. And so whoever is administering that medication, whether that's the assisted living facility, or if they have, well, I don't think 3 times a day they'd have any sort of person coming into the assisted living facility, but you're going to go ahead and coordinate that with medical staff at the assisted living facility and ask them how they questioned this with the primary care provider. If that has been questioned, you can go ahead and document that you've had that conversation. You know, as we well know, you know, if you don't document it, it didn't occur as nurses. And so if there is still some sort of concern, then you're welcome to contact the PCP directly. If the assisted living facility has mentioned to you that they don't find that there's anything wrong and you've actually assessed the patient to be very drowsy, lethargic, then that would definitely be concerning, and I would call, you know, the PCP, or, you know, obviously if it's an emergent situation, you're gonna call 911. But if that's something that you've identified, you're welcome to contact the PCP if that hasn't been adequately looked at by the person who's administering that medication.
Perfect. Thank you.
You're welcome. Do we have any other questions in relation to the form? Okay, so we'll go ahead and move on. So the medication section on that very first page, when you're initially conducting it, you're looking for possible interactions. Again, you're not looking at each and every single medication. We're not doctors, but you are looking for overall whether or not there's any sort of health or safety concerns, just as Shannon identified. You're going to be using your clinical judgment and coordinating with the client or service providers, depending on what their setting is. So to go ahead and give you an example, which we're going to go ahead and put into place when I show you an example of what the form should be looking like. Example 1, for medications, the client's medication list includes furosemide and spironolactone. You recognize that these are both diuretic medications. So you can go ahead and take your very first course of action, which is to clarify that with the assisted living facility or with the home health agency if they're administering that medication. If they've already spoken to the primary care provider, whoever has written that order, and there's no concern on that end, you can go ahead and document that in the narrative section. Or you can choose to, go up one more tier and coordinate that with a primary care provider. Or if the response is insufficient and they feel like there's no concern, you are welcome to go beyond that and coordinate that with the primary care provider. So I do want to touch really quickly on some information on Hipaa and TPO. I know that there has been some concern as to whether or not, offices want to provide you with information. So let's say you reach out to the primary care provider and there's some hindrance as to whether or not they want to give you any sort of information on that client. I do want to let you know that as part of an agency for new choices waiver for the state, you're considered part of TPO. So under federal administrative rule for privacy or HIPAA, you are welcome to notify the primary care provider that you are part of TPO, and that stands for treatment, payment, or operations of this client, especially since they're on the new choices waiver. So under HIPAA, the rule generally prohibits a covered entity from using or disclosing protected health information unless authorized by patients. And so they might request that you sign HIPAA release forms or something like that, or have the client do that. So you might have to do that, but in this particular case, there should be an exception except in the case where there's this prohibition, which would result in unnecessary interference with access to quality healthcare or certain other important public benefits. So that is what both New Choices Waiver and your agencies are covered under. We have a question?
No, Marisol, just wondering if these slides will be available, and we'll send those out to supervisors following the training today.
Thank you. Okay, so example number 2, the client is on warfarin. You recognize that warfarin interacts with other anticoagulating agents as well as many antibiotics and supplements. You also see that the client is using ibuprofen for pain management. So again, you're going to go ahead and contact whoever the agency is or the assisted living facility, whoever's administering those medications. And then if they raise no concern or they've already spoken to maybe the primary care provider, you can go ahead and document that. If you feel like the work that they're doing isn't sufficient, you're welcome to speak to the PCP about possible alternatives. Obviously, the provider is in charge of making that determination. You're just there to act as a second or third set of eyes just to ensure no health and safety concerns exist. So there's a section for laboratory testing. And so that's where you're going to describe services in place, therapeutic medication levels, how is this coordinated, are needs being appropriately met, is there any assistance provided for, I don't think this should be in here, sorry, we'll delete this, and is the client compliant? So in this example, the client has type 2 diabetes that is managed with metformin. So in your mind, you're already formulating the following questions. Is there an order to assess blood glucose? How often? Who's assessing their daily blood glucose if that's necessary? Have there been any discrepancies in the last time frame, let's say the last 3 months? Is the client compliant? What was the last A1C? Is an additional need assessed? Example 2, the client takes warfarin daily and has diabetes. So per your clinical judgment, there should be, let's say, a PT-INR test, maybe some blood glucose monitoring done, maybe some routine labs, obviously. So how often are these done? Who's assessing these? Have there been any discrepancies over the last 3 months? Is there compliance? Are medications changed frequently based on this measurement? Who's assessing this, and is an additional need assessed? And of course, if you notice a discrepancy or non-compliance with the labs, again, you're going to go ahead and contact the provider who is in charge of the laboratory testing. And then again, as a second tier response, you're going to speak to the primary care provider or whoever's ordering those labs. So before I move on to the example that I have, I want to ask if anyone has any questions based off of the information that I've already provided. And if not, we'll move forward.
Marisol, can I ask a quick question?
Sure.
So just if sometimes I run into a client with just a really long list of medications, and I do like at least make sure I'm familiar with what they all are, you know, when we're doing the MDSHC, but I just want to double check. So I'm not expected to like go through some program to ensure that there are no interactions between them all. It's just kind of based on my clinical knowledge.
Right.
Right.
Based
Okay.
on your clinical knowledge
That.
of the
Okay.
second or third set of eyes. The only time you might feel like further investigation is required is if the client is self-administering and they have absolutely no eyes on those medications. That might be a point where you might look more thoroughly at those medications, and usually they don't have as many, but in most cases, there should be another entity that's looking more closely into that. And so again, you're just looking overall and ensuring, you know, that there's no obvious health and safety concerns. Yes, using your clinical judgment. That's a great question, Diane.
Thank you so much.
Sure. All right, so let me go ahead and pull up this medication management review form. Can everyone see that? Hopefully. Make it a little bit bigger. Okay, so in this medication management review form, we do want you to fill it out in its entirety. I did request some medication management review forms from agencies just as a sample, and I chose those randomly. And I'm hearing that someone's not able to see the slides. So right now I'm projecting the medication management review form. And so is everyone able to see that form?
Yeah, we can see it. I think there are some agencies whose like safeguards within their own systems prevent them from seeing our screen, but yes, you're presenting. So.
We'll go ahead and send this example out as well as the PowerPoint.
Yeah.
So with this medication management review form, we want you to fill it in its entirety. As I stated, I grabbed a random sample of medication management review forms and noticed that there were some areas that hadn't been answered or some questions that hadn't been answered. So this is, you know, self-explanatory at the very top. I do want to reiterate, because this seems to be a question that's asked, continues to be asked, is when is the medication management review form due? It is the schedule is based on the most recent MDSHC that's been conducted. So the very last MDSHC. To give you an example, I went ahead and put in a very easy date of January 1st, 2020 as the corresponding MDSHC. And so I also want to reiterate that the due date is going to be essentially every 3 months from this very last MDSHC. So if we look at that schedule, it's going to be for 3 months later, 6 months later, and 9 months later. So first question is asking who's responsible for administering medication. And so in this example, we have that a home health agency nurse is doing that. And so because of that, in this particular example, they're being enrolled from an assisted living facility, and we have a home health agent going, home health nurse going in and setting up their pill box for them. Okay, So in this very first section, what we're looking at is medication administration and compliance. And so in this example, they receive home health services. We have that we've already spoken with the home health nurse, Amanda, who visits this client every 2 weeks. She places the medication in the pill box, and the client's been able to self-demonstrate this process of taking their oral medications. You've been able to assess that it was done successfully, and then the records from the home health agency document that there's been compliance. Next one's going to be medication interactions. The client's home health electronic medication administration record was reviewed and documents 1 tab of furosemide, 1 tab of spironolactone taken every day. So that to you is a possible medication interaction, or a possible, I should say, health and safety concern relating to these orders. Does the client receive laboratory testing is going to be your next question. So you have to respond that. And so in the previous examples that we looked at, we were looking at A1Cs, and we know that they're done, at what frequency, and then where are they getting these laboratories done? So in this particular example, they have their A1Cs done every 6 months due to type 2 diabetes. It's managed with metformin, but the client does go to the PCP office, which is Dr. Howard, to draw these labs, as well as to get routine labs every 6 months, and they've been compliant. I've documented their last A1C of 6.8, which was conducted on November 10th of 2019, and there have been no changes to prescriptions based off of this lab. The client was assessed to be able to monitor their daily blood glucose, and you did that personally. The client's personal logbook demonstrates compliance and ability to record these numbers, and the client self-demonstrated the process of taking daily oral medication, the use of glucometer, and when to report those numbers. They take warfarin daily, and so the INR is monitored every month by the home health nurse. In this last box on that first page, you're going to document any follow-ups. So for example, with the case of the diuretics, a call was placed to the home health nurse, Amanda, and you questioned why both medications were being taken. The home health RN believes that this was done in error, and she's verbalized that she's going to contact Dr. Howard, the PCP, about the possible error. And so the CMA RN, that's, let's say that's me, will continue to monitor for possible medication interactions. So that's our very first page. And I also want to state that with this first page, what it's doing is it's allowing you to jot down any information that you might have to routinely check. So for example, every 6 months, you're going to have to ensure that there's an A1C done, INRs are being done monthly, that sort of thing. It just really opens your eyes to making sure that some of these routine things are being looked at. So it kind of serves as a reminder. Okay, so we're going to go ahead and move on to that second page. And so for Q1, that's due 3 months following the MDSHC. So since it was conducted on 1/1/2020, the due date for this very first quarter is 4/1/2020. Now, there is some confusion as to when you can submit those, but you are able to do it 30 days before, as long as medications are current, or 30 days after to account for time utilized to complete the review process. So in the case that you're having that difficulty, we've given you an entire 30 days after to ensure that that you receive that MAR. And so for this particular process, I would suggest that you start early, but we do give you 30 days to account for that process. So technically, even though the due date is 4/1/2020, you can submit that between 3/1 and 5/1/2020. And then that'll count for Q1. So in this particular Q1, we've documented that there has been some follow-up on the diuretics and that you've coordinated with the home health nurse who stated that she was not able to contact the PCP. So now you're going to contact the PCP directly. We've identified that there were some med changes and that the home health RN continues to come every 2 weeks and places oral medications in the pill box. You've received a copy of the MAR and have included it in your agency's electronic records. You document your name, sign, and date. Otherwise, it's not necessarily valid, so always ensure that this is taking place. For Q2, at this point, the Lasix were discontinued. A1C labs were drawn, so after 6 months, you did notice that that took place. And you've documented the lab number and the date that it was conducted. No changes in medication. You've also discovered that the INR was not assessed for the month of May and were then assessed late. So you coordinate with the home health RN to ensure that she reschedules this appropriately. And that's documented right here. So again, you're going to sign and date. And then in this last quarter, again, you've reviewed the MAR, saved it to your agency's records, as you should be doing every quarter. And in this quarter, there are no changes, no concerns. So that's kind of a nice, easy one. But that very first page has reminded you at what you should be looking at. These areas for you to write in your narrative are basically you re-reviewing those routine areas as well as any additional concerns that should come up. So even though there's nothing that you've identified as a health and safety concern for Q3, you're still going to review the MAR and document that you've reviewed it and document what else you might have noticed or any changes relating to health and safety concerns. We don't want to see this box being completely empty. And so you're going to go ahead and sign and date.
Marisol, we did have a few questions come through the chat. Do you want me to read them off for you?
Sounds good.
Okay. Brooke said, oftentimes we have very difficult time getting current medication lists and the MAR from our buildings. Any suggestions on what to do if we can't obtain these documents from our buildings to complete the review on time?
I think that goes hand in hand with the service auth forms.
Yeah, it does. Brooke, can I ask what are some of the strategies or creative solutions you guys have tried to kind of turn over every stone? Maybe there's something we can think of to add to that.
Calling over and over and over and over, or going straight into the building. We have some buildings where only specific people can print off the medication lists. And if they're not in the building, that makes it difficult because there's nobody else there that can get it for us at that time. So sometimes we're just waiting for the right person to be able to get it to us, and then it never happens. Or yeah, so if anybody has suggestions or ideas on what they do, I would love to hear them.
Well, and sometimes when people haven't been able to print them, it's like some staff just seem not to know how to do that. I have just said, can I review it on your screen? So I wasn't aware, do we always have to upload it to our system? Because like on the MAR, it just says, have you reviewed it? So if they're like, have difficulty in the facility printing, because sometimes it is like 20 pages if they were going to print all the, and I said, can I review it on your computer? And I'll just sit and review them, but then I wouldn't have a record. Is that a problem if I don't have a record of it?
I'll defer to Lainey. I think as long as you document that that's what's occurring and that you document that you don't have a medication management or you don't have the MAR included in this review form and upload it to your agency's records, then I think you're providing sufficient narrative to understand why that is. Lainey, would you concur? Do you feel like it's necessary?
No, I think documenting it that you've reviewed it in their system is appropriate. And you know that is the reason why it's not a record in your system. I do think we need to work through the issue of providers not giving you the information. So I don't want that to become the default for lack of response by the person you're trying to get a hold of. I think we need to work through that separately. But to your question directly, Diana, and how Marisol answered it, I agree.
Okay, and then sorry, one other thing. I wasn't aware we were supposed to be uploading the MARs. I'm sorry, just like based on it, it just said, have you reviewed it? So I would get, most often they can give you a printed copy. And so I do review it, but I haven't been uploading them to HEF. Do you want those all, I mean, sorry, to our system. Do you want those always uploaded?
I think retroactively, it's not necessary as there hasn't been clarification given, but I think at this point, for your own practice, that might be something good for you to have so that you can, you know, back up whatever your narrative is based off of the MAR. So I think that's just best practice for you, as well as for auditing purposes. It shows that, yes, you have looked at that MAR. You know, anyone can very easily just state that, you know, and I highly doubt an RN would ever sign off on that, but it just backs up any of your documentation.
Melissa, you have your hand raised, and then we'll continue on with the chat questions.
Yeah, I've read some of the comments come through too. So a couple of comments. I have gone to the administrator before when I can't get the nurse to respond to me or email me, or sometimes a med tech will do it. So try multiple people in the facility and multiple times. I've even go to the primary care where we have these rounding physicians in a lot of our buildings. The MAs, if you can get to know them, they've been a huge resource for me. But I'm not getting MARS. I'm getting just a med list. So I can compare that to my other med lists. And somebody had commented, it's hard to get 3 months of MARS. We're lucky if we get 1 month of MARS, which is true. And most of the time it's just a med list. And so I can do all of that with it. But the struggle is real for sure. But then trying the pharmacy too. So those multiple avenues to try and get a med list. And I can start asking more, like the nurse or whoever I'm talking to, will you look at the MAR and see if they're taking their meds routinely? Are they missing meds? Are they refusing them? And I can do more of that information instead of having them send me 3 months of MARS. I can just ask. Maybe that'd be easier too. But I don't know. That's my thoughts.
Yeah, you bring up some really great points, Melissa. I think that that's excellent. Again, if you have a telephonic conversation, you know, just document that, the mode that was used. I don't know if anyone is used to emailing, if they've been successful with emailing and, you know, advising that there is a due date, you know, to continue case managing this person. Does anyone email?
Hey Marisol, this is Jessica. I'm a nurse with Envision Quality. I have a couple of things that we do, and tell me your opinions if they're okay with your practice for documenting and getting information. And maybe it's also helpful if it's working for us. But I do sympathize. It is super hard to get MARS, super hard to get information back timely. So that I know someone had posted that you would have to up the units because it takes a lot of our time to get this information. And if you're wanting us to get printouts, that's going to be more time. So that was one thing. But something that we do that has worked out really well is when we do our initial medication assessment with our MDS is we contact their PCP. I usually call the PCP just to confirm, like, hey, this is still your client. And they're like, yes. And then I get a contact, whether it's through email or fax, and I tell them I'm going to be sending you a paper. Can you please watch for it? And then, you know, get it back to me timely. And then the paper that we send over, we've formulated just a one sheet that has I'm needing, the clients, their medication lists, any therapeutic labs, what they are, and are you monitoring them? And just very matter of fact, bullet point things, so that's, very easy for them to fill out. And then we ask them to give that back to us. Is that okay? Because that's where I'm getting the doctor's recognition and acceptance that they are, one, monitoring the patient for their medications, their interactions, their dosing, and they're monitoring the labs, because they're signing that and they're sending it back to me. So I feel like that is enough. So I want to know if that's okay. And then also for the quarterly checks, we have contacted the facility where they're at. And again, I have a paper that we send over that just says, the nurse or the facility has looked at their MARS for the last 3 months and they are compliant. Or if there's any concerns, they tell us on that. Sometimes it's email, sometimes it's fax, but it is sent back to us with their signature from the medical staff stating that they have looked into it and they are compliant, or, these are the concerns.
Lainey.
So if I'm understanding correctly, the information that you're getting is more like a certification that certain things are occurring. Or are you getting evidence that those things are occurring?
When I talk to the PCP, I'm getting certification that this is their current med list. These are the labs that they are getting routinely, for checking meds. And I'm getting that they are aware and monitoring any medications and looking for interactions, or however you stated it on your paper. And they're doing that. So that is, I guess, just a validation from the doctor saying yes to that. Is that enough to document?
A couple thoughts. I think that's a really genius strategy when you're working with providers. And I think there's opportunity for us to maybe build on that. I'm not quite sure, and maybe this is where I don't know enough about nursing, right? So you guys fill me in, but I'm not quite sure if that accomplishes the goal of a second set of eyes to kind of act as a safeguard in case something is missed in the doctor's review. So I guess I will kind of maybe put that back to see what you guys think, Jessica and Marisol.
Right. And I would agree with that estimation. I feel like that is a really great way to try to accomplish that, as long as there is that current medication list. And as long as you, again, provide that second set of eyes, even though they've verified that everything seems perfectly fine, you're still going to want to review that and get back to them if you see any health or safety concerns, even though they've verified that everything appears to be correct and that there are no interactions.
Usually I've noticed when they do send it back, they are sending back so most of the doctors, and this is a generalization, have sent back the current med list, and then they usually send back because a lot of them are like, oh, I haven't seen that patient in a year, and so then they send out their PA or whomever, and they do an assessment and all that stuff, and they usually send a copy of that as well, and that's been super helpful because then it is letting me know that, hey, you are looking after this patient and you're aware of these things, and brings to light a lot of the issues that are that like I've noticed when we do the assessment. So that has been helpful. That isn't always the case, but when they do send that, it helps, and it does show the labs and stuff, but that isn't all of the doctors. But I mean, if we could get that every time, that would be like golden.
That would be dreamy, right? I think we might not be in the best position to definitively say yes or no. I think there's room to explore what's working and what could be improved upon. So if you're willing, Jessica, if you could send Marisol like an example of one that you feel like the physician's response knocks it out of the park, right? And checks all the boxes for the intent of what we're trying to do, where they provide like evidence of the labs, or there's some like as a result of your contact, follow-up was initiated that may not have otherwise happened, like you know, a reassessment. And then maybe send us one where you're not quite sure if this is adequate, exactly what you posed the question of before. That would be really helpful. And then maybe that will give us a better sense of what you're working with, because it sounds like that might be a strategy that would work for everyone in the group. You know, we don't want to be too prescriptive to say you have to accomplish this, you know, step 1, step 2, step 3. But if that's an option that can be replicated for everyone, if it works that well, I think it's safe to say that there would be interest in that. Correct me if I'm wrong, you guys. Okay, so Jessica, hopefully we can look out for that information from you. We would really appreciate it. And then we will take note that that's a question we will need to answer as a follow-up for this meeting.
Okay, I will send the blank form that we sent so you can kind of see what we're asking to make sure that it covers all the bases. And I will send you one completed. Can you put in the chat the best email to send it to, please?
Yeah, we'll have you send it directly to Marisol. And all your questions to Marisol from now and forevermore. All right. So let's see. We have a couple more questions. Oh, Amy, you want to?
Yes. So some of the feedback I'm getting from the ALFs is just that it's very burdensome for them to have, you know, some of the new choice waiver clients, because a lot of them are much higher need, and then we require quite a bit from them. And I've had one facility say, we do med management reviews. Can't I just tell you that we're doing them and they're good? So I don't know, you know, because it does take them a lot of time, and it takes, I had a facility where I reached out to them probably 4 or 5 times, different people, and finally was able to get the information. But I'm getting that from them too, that they feel like it's very burdensome for them to have to give us the MARs, give us new med lists, check on whatever. And I've never had any luck getting a response from PCP. I think it depends on who it is, and the ones I've reached out to have big offices. And so I have to leave a message hoping that a nurse will call me back. I've called several times and never had a response. So I think those are hard things. You know, home health nurses have a little different relationship, I think, with the ordering physician. And if we also already have a home health nurse, and then we're also trying to reach out to the PCP, sometimes I just don't want it to be such a burden to them that they're like, this isn't for us. So,
and if there is a home health agency nurse, that should be your first point of contact before reaching out to the primary care provider. That would be just like your second tier.
Which I've done before, but she has said those lab draws are done in office. You'll have to contact the physician. You know, and so it just, I don't know if it's enough to just say done in office routinely, or if I need to call and get all of those labs. I think it just depends on the situation, you know, but the most recent one, even at the facility, and it was a physician who came to the facility, they said, you know, he monitors that. You'll have to reach out to his office. And anyway, so they didn't have any record of blood draws at the facility, even though the physician was coming to the facility.
And again, I would leave that to your own clinical judgment as to whether or not you feel that might be a health and safety concern, and if you need to continue to pursue other avenues to retrieve that information.
Okay, and then most of my clients on hospice are not getting any blood draws. And so is that appropriate to just put on hospice, no labs drawn?
Right. So again, you're going to use your clinical judgment as to whether or not you feel like that's a health and safety concern for someone who's on hospice. Yeah.
I think what your conversation speaks to is maybe the degree of care coordination that has happened in the past versus what we're trying to accomplish with the med management reviews, or what could be accomplished, say, if New Choices Waiver as a program had a greater, I don't want to misspeak because I know you guys work well with providers. So this is not a criticism toward the work that you guys have been doing, but I've heard this before, the concern with providers getting back to you. And if it was well known that the expectation for New Choices Waiver is interdisciplinary care coordination and case management, I wonder if this would not be as much of a challenge. Do you guys agree or disagree with that as maybe kind of an underlying challenge with this scenario, or any other case management strategy you guys are trying to do? So I'm going to assume no, if no one's saying yes, that's not a problem.
I do think, I don't know if you've been able to read some of the chats, but I do think some of the nurses feel like it's a duplication.
That it's a duplication. Okay.
Yeah, what really the ALF should be doing with the PCP that's already there. And with the home health nurse, what they should be doing with the PCP. So if they're the second set of eyes, then are we the third or the fourth or the fifth?
Mm-hmm.
And I think to them, it becomes burdensome. That's my honest opinion. I'm sorry.
Yeah, no, I know, I'm assuming positive intent. So thank you for bringing that perspective. Is anyone in the group coordinating with the home health or the assisted living nurse to complete both of your reviews at the same time? Or to do that, not necessarily together, but so that the MAR only needs to be reviewed once and you guys are doing it at the same time to accomplish both of your needs?
Lainey, I think there would be resistance to that with multiple CMAs coming in and wanting to do it, on our schedule. The feeling that we get from not only assisted living providers, but home health nurses and doctors is, why are you guys asking this? We've already covered it. Leave us alone. And so that is a barrier. And I think the smaller assisted livings might be amenable to it, but I don't think the big assisted livings would be open to doing their stuff at the same time as us. I think it would be an inconvenience, and I don't think they would comply.
Okay. So knowing that because of federal requirements, it's not an option to do away with medication management reviews. Do you guys see a solution? I will fully admit you're in the field, so you probably you have ideas that we don't have because we're not doing the work. So do you guys see a solution, or is there something that you're like, man, I wish New Choices Waiver would just take this strategy that would accomplish the same thing as our agency acting as a set of eyes?
So Lainey, could it be that we document, because I always talk to the home health nurse and I try to either talk to the med techs or the director of nursing. Is it enough to just ask them, have you done a review, so that we can just document, or do you want all the specifics? Because if they are the, second set of eyes, then maybe we could just document that they have done that and that we've reached out to them and just say lab draws were done last visit, in August or whatever, but not have all of the details. I don't know if that would be enough to meet that federal guideline.
What details? I'm sorry, this is
sorry, the lab results, the actual results, and the exact, because sometimes they will just say my labs were drawn. He always does my A1C or whatever, you know, every 3 months, every 6 months, thyroid yearly or whatever. Is that enough, or do we need the exact results?
I think that Marisol, unless you have a gut reaction to that, that might be something we can take back and work through.
Well, again, the expectation isn't that you look at each and every single one of the results or each and every single one of the medications for that matter. It's just to use your clinical judgment and see whether or not there are any health and safety concerns. It's not you being like a bedside nurse and looking at every single thing. It's looking at the overall status of each individual and their particular needs and their particular diagnoses and their situation to see if you feel like there are any health and safety concerns more than anything, any interactions. In the example that I gave previously, there was documentation of an A1C, and you know, I happened to get the number on that and the date that it was done, and then that way I knew, you know, 6 months from now, are they going to get it? So it just acts as a record for me to continually check on that. But it's not meant to be, you know, is this outside of normal range? Or, you know, that would be more along the lines of the home health nurse that's supposed to be doing that. Does that clarify it?
Yes, thank you. I was just going off of that example you gave. It was much more specific.
Yeah.
Anticipated.
And that's not the expectation for you to put, you know, like 7.1, and no, it's, you know, just for you, because you have that information and you've documented it for the future. You know, if you happen to see something that's completely, you know, different to that range, then it might be an eye opener for you. But again, it's using your clinical judgment for health and safety concerns.
So is it accurate to say that one of the goals, in addition to identifying health and safety concerns, is to identify any needed referrals or care coordination? Not to say like that New Choices waiver is the one to do that, but there's this issue, is someone addressing this?
Right, is someone's eyes looking at this? And usually that's going to be more for the home health nurse. Obviously, there's going to be situations where someone's living at home and they're self-administering their medications. Then that's when you're going to have, you know, more keen eye on the situation. At which point that might be something, you know, that might require a referral, and they're living, let's say, independently, self-administering medication. Then that might be a discussion to have with the client and with the representative to see, you know, has this additional action taken place.
Okay, so if we were to put together a handbook for this, we need two different scenarios: someone living at home or managing their own medications, and then someone in an assisted living or on home health, and how those services could be leveraged to meet the program's requirements.
Great.
Okay. I think that's clarifying material that we can put together for sure.
Lainey, Rob raised a question of it might be helpful if we could see the federal requirements and maybe give us a month or so to noodle it over about what it actually looks like in the field basis what the federal regs are, and maybe allow people some time to come up with some suggestions based on how it actually works in real life.
Yeah. Yeah, I think when I say federal requirements, I'll clarify. It's not in, you know, Code of Federal Regulation. For waivers, we are required to demonstrate quality assurance strategies. And I will go back and refresh before giving specifics, but it is our state implementation plan, quality assurance strategy to have medication management monitoring. So that's a great suggestion. And Anna, if you'll take note of that as an action item for us, that we will send that out you know, outline what the requirements are, what our strategy is, and then elicit feedback for what you guys think might work. Thank you for doing that.
So I'm going to head back over to the PowerPoint as we approach the end of this meeting. And if we have time to solicit questions and for you guys to ask questions, we'll go ahead and go through that. But I did want to go over some additional information. So some additional items that you're going to want to coordinate medication management activities with the assisted living facility, home health, client, family, or representative. As a second tier solution, you're going to contact the PCP if specific or immediate concerns are identified and they have not been resolved. The medication management review may be completed 30 days before or after the due date. You're going to scan the form along with the MAR or a current med list each quarter. And we already discussed, you know, if you've had a conversation in regards to MAR or current medication list along with medication compliance, you're welcome to document that in the narrative as well. Others are not allowed to conduct the review. And so what that means is essentially you're not allowed to fax this specific form, this medication management review form, to other entities. However, you can use other medical professionals as a resource, as you have been doing to fill those out. Ensure all documents are kept in electronic files as they may be requested for auditing purposes. The RN telehealth visits may count as fulfilling the monthly contact by CMA requirement. And so I don't know if this is being utilized by CMAs. We'll go ahead and ask that afterwards. When performing an initial MDS-HC assessment, use the current medication list provided by the skilled nursing facility and review this with the client and or family for accuracy. For follow-up quarters, that is quarters 1, 2, 3, and on, if the client is in a skilled nursing facility on the due date, so in our example, the first medication management review form was conducted on 1/1/2020. The next one was due on 4/1/2020. If on 4/1/2020, the client is in a skilled nursing facility, you may document this in the narrative section of the form that you were unable to complete because the skilled nursing facility is conducting those reviews, and that would be a duplication of services. You're still able to initiate disenrolling clients after 90 days of being at the skilled nursing facility. And per our last meeting, if the applicant is no longer meeting nursing facility level of care. And again, you may document this in the narrative box if they have been discharged by the date that it's due. Complete the form in its entirety. So at minimum, always document that you've reviewed the medication administration and med list for each quarter, and that you can substantiate that there are no concerns for that quarter. And then ensure that the medication management review corresponds with the most recent MDS-HC. And when in doubt, contact New Choices waiver. So again, we can continue to ask questions.
I'm just reading some of the comments in the chat, and there's some themes. You know, the concern about duplication of services, maybe feeling like case management, New Choices waiver case manager RNs are stepping on the toes of others who are doing similar activities, or feeling like our program is activity is a burden to providers who are maybe on the fence already about participating in New Choices waiver as a provider. Time, how much time it takes to get the required information. That is an interesting one. I think it would be helpful for us to know your thoughts about how much time it's taking. When we presented this, I think that question did come up, and something that we had worked through, and we estimated that it may be, 2 units a quarter, with the assumption that we make a request for records, it gets answered, and then the nurse completes the form and reviews it. So how has that been working in practice? How much time are you finding that you are spending on this?
So Lainey, this is Susie. Hi, I shared an example of just one. It was my initial medication management review. Actually, it was an annual on this client, and it was 100 pages to get 3 months of the MAR. And they didn't want to fax 100 pages, which I understand. It cost both of us to fax this. So I ran and picked it up in person, but then I felt bad. They had actually printed 100 pages. And then, so I had to make the initial time to contact them back and forth a couple of times that they weren't going to fax it. They'd have it ready for me. I went and picked it up and then brought it home, and to look through 100 pages just to see that they were compliant with each med. It was the way that their software printed it out, but I had to look on every page to see if the client was refusing or taking the med, or if it was held because the pharmacy hadn't provided it on time. So I had to look through 100 pages and then complete the medication management review, but now I have it in paper. So then I've got to scan it and upload it to my own system for recovery. So in that one instance, I was at least 3 hours into the medication management review part on top of the regular what you do for the annual. Not all of them are that complicated, but you do find some that are that complicated.
Okay. That's helpful to know. Thank you. Let's see. Brooke said right now about 45 minutes, but now that I understand better, it will take significantly longer. Okay. Takes at least an hour or more to get all the information, about an hour. Okay. That's good feedback for us to know. Someone else also made a comment about cost benefit analysis. That will be happening after this conversation as we look at, the requirements and the objective. We do see that this is something that's important to be done since we are a medical program. We think that this is demonstrating care coordination between providers, and that's valuable. So it will be helpful to send out the information to you all and get your thoughts about what this could look like if you were in charge of creating this this process, knowing the objectives, what you think would be possible. Let's see. Maybe if we emphasized with facilities that missed or refused meds are a medication error that needs to be reported as it occurs, we would not need the MAR. If I find out about missed meds 3 months after it happens, that doesn't help the client very much. You're right. I know that is one of the goals of this review, is to identify any unreported medication administration errors. So it sounds like communication with the assisted living providers is needed. One, to kind of build the relationship between them and New Choices Waiver as a whole, for care coordination, to hopefully make getting responses easier. And then also reinforcing incident management procedures. All right, is there anybody with a hand raised? I haven't looked at that recently. We've got 7 minutes. So if anyone has any last minute questions, or if I missed a comment in the chat that you were wanting to go over, please unmute and just ask your question.
I think it's important. Can you hear me?
Yeah.
To make the, as nurses, we know the difference between an MAR, medication administration reconciliation, and just a med list. So if you have a client that gets one pill 4 times a day, every time that's given, it's put on the MAR, or some facilities circle it and put not given, patient refused, on and on and on. So that's why these lists for 3 months can be 100 pages. And I'm not sure that that oversight in that depth is really what the goal is of this procedure, this process. And so I don't want anybody to think that we just feel like we don't want, as nurses, to do this oversight. It's just we need some guidance on the depth that this needs to be done and the value that that brings. Mm-hmm. I did have a client on a medication that the dose was really, really high. And so as a nurse, I educated myself on the dose normal limits. And then I contacted the facility and we had a discussion, and I thought that was very beneficial. And so or I had another client taking a diuretic without potassium. I think that warrants a conversation. But, those are the larger things that stand out. But the level of the medication reconciliation is really, really deep. So anyway, I just wanted to put my 2 cents worth in.
Okay. No, that's helpful. Marisol, did you have anything you wanted to say there?
Yeah, I think, speaking to Christine's point, that's really great. With you receiving the MAR, you're not going to look at every single administration of the medication. We're looking again just to see if there's any things that are just popping out at us. Christine was able to notice one of the medications had a high dosage. And so that was concerning. That was a health and safety concern. That might be something that she needed to communicate with the facility or with the PCP, because that seemed to be something that was flagged for her. So that's what I'm wanting to see with these medication management reviews. It's not necessarily that you're looking at each and every administration. If you're able to verify that the client's, compliant or generally compliant, because if you were to look at each and every single administration, you might notice, there's likely some non-compliance, somewhere in there, or, a medication was given late at some point. But it's just the overall, whether or not you see any flags basically in the current med list and administration of those medications. Generally, you're not looking at each and every single medication, each and every single administration. You're not looking at each and every lab or therapeutic level. You're looking at whether or not there's, a flag that someone else has missed, really. So that's why I don't think it should be necessary to apply as much time to have to look at this information, but it's definitely eye-opening to me to see that, people are looking at, each and every entry for the MAR, or expected to look at each and every entry of the MAR. I hope that we can relay that that's not the expectation. It's to really just look overall and see if there's any flags that have been missed.
All right. Oh, is it Sherry?
Sherry.
Sorry, go ahead.
Okay, so just to clarify, I work with Envision Quality with Jessica, and just to clarify, are we supposed to be getting a complete full medication administration record for the past 3 months, or is a med list okay when we do these quarterly management things? Because as we've been seeing, some of these pages can be like 100 pages. So that's going to be a lot of stuff that we're going to be reviewing and holding on to, both on our electronic record and on our paper forms. So when we look through the comment list from what people are saying, is it the MAR or the med list that we should be collecting and uploading and saving?
So I should fulfill that requirement if you receive a current med list and you're able to verify that the client's been compliant, then I don't see that there should be a problem with documenting that and how that information was retrieved.
Okay.
Lainey, do you see a problem with that?
That's
the way
that could probably clarify in guidance.
Yeah, the way that from what I was reading in the work group, I think that was the initial thought, was that you could receive either a current med list and ensure that there's compliance, and see who's administering that and that sort of thing, or a MAR. And so you can choose either direction, whichever would suit the purposes of fulfilling that requirement.
Okay, so along with receiving that med list, we do have a form that we have the facilities complete, which provides an acknowledgement that they have the client is compliant with the medication, and they're, if it's an assisted living, they're responsible for the administration for that. So I think that kind of ticks off both of those boxes that you're talking about. So I think that's good. Thank you.
Yeah, and I'd love to see examples of those. So if you're welcome to send those over to me, and then that way we can kind of establish some standardized practice for some of those forms that everyone else is using. That way it could help out all the case management agencies.
Great, thank you.
Thank you.
All right, we had one last question in the chat about care plans. We're having difficulty with care plans being approved in a timely way. Is there something that we as CMAs can do to help, or is there a way to speed up the process? Everyone is on the same page there. How can we speed up this process? I appreciate that you're asking what you guys can do to help. If you weren't here at the beginning, there's a Google form that was created to get feedback, essentially asking what we can do to help. And we wanted to shy away from taking the approach of saying, okay, CMAs, this is what you need to do. Why are you not doing this and this and this and this? So I appreciate that you're asking that question. And I think that's something that we can talk about hopefully in the future after we gather some more information. And I can maybe ask some questions to clarify what you guys are meaning by some of the responses that are being submitted to that Google form, and maybe we can work together. I think there's general acknowledgement from both of us, both sides, that there's things that the state is doing that may be not helping, and there are things that you guys are doing that may not be helping, but everybody's interested in making it better. So we'll get there. And thanks for asking that question. So if you don't have the link to that form, please get with your supervisor so that they can give it to you. I'm interested in hearing your feedback. Really appreciate the discussion. Love the opportunity to work together through policy versus practicality. We agree. This has been really helpful. So thank you for participating. We're over time, so we will let you go. But thank you so much. And we will, I'm sure, talk more soon about this topic. So thanks, everyone. Have a great day.